I'm actually really excited to do this because the TOPS technology has been a game changer for me. Why don't I show this PowerPoint? Is that how we'll start it, Jeff?
Yeah, that'd be great.
Okay, perfect. So here we are.
Yeah.
And can everyone see this okay?
Yes, looks good.
Right. So my name's Shelby Burks. I'm a neurosurgeon, board certified neurosurgeon at the University of Miami. In the Department of Neurosurgery, we have about 21 of us. We're a very large spine department. And I've really been interested in motion preservation, and that's how TOPS caught my eye. And it was really, I'll show a case, but I remember my first case was about 1 year ago, and I think that's when we got this picture. And I've since done 11 TOPS cases. I just looked at it. I haven't had any issues. In fact, everyone has done very, very well. In my first 11, it's been great. I've been able to even teach some of my colleagues about it already, and some other people in the state, friends of mine. Uh, but I just found it because I just was tired of having to fuse, you know, young people especially, but anybody having to do a fusion because of a small degenerative spondy when the problem is really stenosis. And we'll get into that a little bit in our case. And I want to provide several key learning points that I've picked up along the way. And so here's a case that'll kind of illustrate a few of the strengths of the tops. Let me just see here. So and our first lesson is patient symptoms together with radiographic imaging provide a complete picture of what's going on, the patient's status. And that's why we ask people to come in with MRIs, in particular, the MRI is critical. CT also, and it should be less than a year old in general. And that's just, you know, in the setting of needing surgery, that's pretty much everyone's rule. Um, And this patient had neurogenic claudication symptoms, which are basically leg symptoms with walking. So it'll be sort of cramping pain down the backs of the legs. And the patient complained at different times about pain, tingling, cramping, weakness, and heaviness in the legs. And in this case, the symptoms were more dominant in the legs and the lower back, and they're aggravated by walking or standing. They're relieved with sitting or bending forward. It's kind of, we learned this in medical schools, the shopping cart sign. So when you lean forward on a shopping cart, you open up a little bit of space in the spinal canal, and that'll often be how someone deals with lumbar stenosis. They'll bend far forward, and that'll open up a little bit of space. And that's one of the features of lumbar, of neurogenic claudication and making that diagnosis. So here's a sagittal MRI here, and you can see that the disc and the ligament, I don't know if you see my mouse, but the ligament's in the back, the disc is in the front, but the nerves are being pinched as they travel through this canal. And that confirms this diagnosis of spinal stenosis. The other diagnosis that's going on here is spondylolisthesis. And if you haven't heard this term, it basically just means a slippage of one vertebra on another. We call it a spondylolisthesis, a slip, a deformity. And this is really where the TOPS device shines. Um, and let me show you how. So basically, our second lesson is well, we like to operate on patients when there's a clear plan and likelihood that we can do good for the patient. So essentially just means that if the imaging fits the story, and there's so many people that I see and I'd love to help them, but I just can't figure out exactly how based on the imaging. But this is a gentleman who I saw who he's got these symptoms and the imaging fits, and we say, yeah, this is a good case for surgery. In this patient, and I felt he was a good candidate for a decompression at both of the levels shown here, L3, 4, and 4, 5. Ideally, you'd just leave it at that. But because of his spondylolisthesis at 4-5, and you'd see it even more on an X-ray, I didn't feel that a decompression alone would be helpful. And this is where you'll hear five different answers from five different surgeons. What should be done here, but probably the most common thing you'll see is a fusion. In a degenerative spondylolisthesis with severe stenosis, you're often going to see a fusion. And in some way, I believe that that level needs to be stabilized. Here's where the TOPS device comes in. That allows us to do a decompression from L3 to L5 and then put the TOPS device at 4 or 5. So now we've decompressed and we've stabilized, but we haven't done a fusion, which has its issues that we know about. And so lesson three, this goes right into it, is we choose to maintain motion when possible. And not only does that allow for a quicker recovery, I believe, but it also delays this adjacent segment disease because when you fuse and lock two bones together, it essentially puts more stress on the level above and below. So in this guy, if you just treated 4 or 5 with a fusion, that L3, 4 level is going to wear out very quickly. And if you fuse L3 to 5, now you're talking about a 2 level fusion, and likely that L2 to 3 level will wear out ultimately. And so that's why the TOPS device is powerful because we're able to put it in that L4-5 level. We maintain motion at that segment. And what the data shows is that reduces adjacent segment disease. And so here's some photos of the x-rays. You can see this is what the device looks like in the patient. And he did very well with this. He was able to come off of, he had been on pain medications for a very long time, and he was able to come off of that. He was able to be more active. I remember seeing he and his wife in clinic. Really, we say it's about 6 weeks before you're really recovered. And I think that's about when I saw them in clinic, and he was doing amazing at that time. And so I'm very grateful to be able to use this system and help patients with this. It's really been a game changer in my practice. Um, and so here's a little bit about the indications of the device. You'll see sort of this neat graphic that shows how it moves. And so once you remove bone, including the facet joints and posterior elements, we're able to place pedicle screws. And this device then attaches pedicle screws to the same vertebrae and then allows for motion at that segment. It's indicated it's a motion preserving spinal implant that's inserted into the lumbar vertebral joint and affixed to the spine via pedicle screws, which I mentioned. It's intended to stabilize the spine following a lumbar decompression without rigid fixation. It's indicated for patients between age 35 and 80 with symptomatic degenerative spondylolisthesis up to grade 1 with moderate to severe spinal stenosis due to either thickening of the ligament or scarring of the facet joint capsule. And it's indicated from L3 to L5, L3-4 or L4-5. Here are some of the biomechanical data showing that it does in fact preserve motion in real patients. And I've seen this myself. I always get x-rays and a CT afterward, and you'll see it actually does reduce the spondy just a little bit. We don't want to fully reduce the spondy, but it definitely preserves motion. You can see that that level moves on flexion extension. I've gotten films immediately post-op and then out a year later, and we see that it's still moving. It preserves lateral bending as well. And all of this goes a long way to reducing stress on the adjacent segment disc and the adjacent segment in general. And this has been shown in biomechanical studies that the Premia folks have done over the years, showing that with the TOPS at 4-5, the stress on the disc above is much less than that of a fusion. And so, what are the indications? How can it be used? It's basically a single level degenerative spondylolisthesis. It can be unstable or stable with severe stenosis. In general, for the trial and for the strict indications, you want to have some disc height and definitely not like a huge disc herniation. Ideally, more leg than back symptoms, and it's helpful with active individuals because that tends to represent a better bone quality as well. And if there's not ongoing pathologies like ankylosing spondylitis or dish, that's important. It can be used adjacent to an existing fusion, and that's, I think, where we're really going to see a big impact. Patients who've already been fused, and then we can put the TOPS above that. And I've done a few cases like that. A primary procedure with the fusion at one level, and then the motion preservation at the level above. So maybe you fuse 5-1 and then you do the TOPS at 4-5, or fuse 4-5 and do the TOPS at 3-4. And then if you, let's say a patient's already had a laminectomy and they still have stenosis, the TOPS is perfect for that because you can remove the facet joints entirely, similarly like a failed Coflex. A facet cyst, this is a very controversial subject in spine surgery. Facet cyst, what I like to do is just remove the facet cyst, but they have a high recurrence rate and they have a high dural tear rate. And so if you go in there and just take out the facet joint completely, then What can you do after that? Well, TOPS is an option. A multi-level decompression for stenosis, as that's the case we showed, with the top at one level with the spondy, and it allows for full segmental motion at the level it's placed in. So that's everything I have. Here's my contact information. Please feel free to email me. It comes directly to my phone. Happy to, I try to get through most of the emails. If not, call our office. We'll get you plugged in. I'm happy to see you in clinic and discuss further.
Great, Dr. Burks, that was great. Thank you. Additionally, you'll see on this slide, everyone, if you want to contact Premia directly, you can contact Shelby George. And we'll leave this slide up for the remainder of the webinar so that you have plenty of time to either take a picture of this with your phone or write down the email and phone numbers here.
Yeah.
Um,
Premia does a
oh,
good job of matching you up with a surgeon in your area, if you're not near Miami, for example.
yeah, absolutely. Thank you. I'll remind everyone that we're going to use the Q&A function now to ask questions. So we've started with a couple of questions here. So let's get started, Dr. Burks. Are you ready?
I'm ready.
All right. This one says, my MRI report shows a broad disc bulge at L45. Does this contraindicate the use of TOPS because of this bulge in my disc?
In general, no, definitely not. I would say yeah, there's a lot to unpack there. One, it really depends on which radiologist are reading it, and you probably notice that they say several areas of disc bulging. That's just a physiologic change with age, and the discs collapse. But no, the short answer is no, it would not preclude you. Now, if it's a huge disc herniation or the stenosis is really due to a large disc, that's something we would see by looking at the MRI. But the short answer is no, that would not preclude you.
Okay. Here's one. Well, first question, there's a couple of questions tied into this, but the first is TOPS. So I'll ask it. I'll ask like two or three of them if you can remember to remember them to answer all of them. First, is TOPS accomplished posteriorly? We'll just say the answer is yes.
Yeah.
Yes, we know the answer to that. Um, is bone density of the vertebra determined before attempting the procedure?
Yes, yeah, definitely. I always check the bone density beforehand, because you do want to have, some strong bone to hold on to. It's the same challenge that you'd have with it, trying to fuse someone with low bone density. Um, just being able to interface the screw in the bone, you'd like the bone to grip the screw pretty nicely.
Yeah.
So yes, but as long as you don't have frank osteoporosis, you still could be a candidate for the TOPS device. And there's some new biologics coming on along the line that can help if osteoporosis is an issue.
In fact, the next question that came up is that exact question. Is I have osteoporosis. Um, could I still be a patient? Could I still be applicable for TOPS?
Right. Then it gets a little controversial and you'd be kind of you'd probably be outside of the actual like IDE indications for the device. Um, in certain cases, you still can, but it would be a little bit of uncharted territory. The unfortunate thing is too, fusing a patient with osteoporosis can be challenging as well. So in those cases, we just have to understand going in that, that's something we need to look for. Every patient like that, I try to set up with a rheumatologist so we can get, if possible, on an osteobiologic, on like Forteo or one of the like.
Here's a question. Will it help progressive lateral numbness when I walk?
Well, usually the numbness from um, claudication and stenosis in the lumbar spine is down the backs of the legs and involving the feet. Now, if it's like the lateral thigh, sometimes that can actually be from something totally different. So you'd have to sort of see where is that numbness. If it is due to claudication and severe compression in the lumbar spine, then yes, it can help with that. And what I would say, look at for the MRI report. look for the phrase severe stenosis. If you see that, then I mean, I don't want to be too paint too broad a picture, but in general, you should probably speak with a spine surgeon if your MRI report says severe stenosis. Um, I can't think of an exception to that off the top of my head, but yeah, at
Okay.
least speak to one.
Yeah, a lot of our attendees of these webinars have seen a spine surgeon, and you know it's
Recommended a fusion, probably.
recommended a fusion. I
Now
mean,
we're
I'm
looking for alternatives.
yeah, and I look, I really admire those of you that have shown up to this webinar, and we do this every 2 weeks, and we have typically 50 plus people show up to these webinars, taking, and I look at it as you're just taking charge of your care, right? You're educating yourself, and you're making sure that you understand all your options. I admire that, and I appreciate everyone that has shown up to this particular webinar. Here's a question that you can answer. I know I can help with this answer as well. Is um, I well, I'm Medicare age, so is this covered by Medicare?
If you want to
I
weigh in
guess
on
I
that
can answer
one,
that.
yeah,
Yes,
why
it's
don't you
covered by
take that?
Medicare. Yeah. Um, if you have yeah, if you have Medicare, it's covered by Medicare. So that should work really well for you. If you have commercial insurance, some commercial insurance companies still consider this experimental, which makes no sense considering it has FDA approval with some very good data showing superiority to fusion. But that's just the way the insurance companies work. But we help with that. We help our customers navigate that. A lot of times we will appeal commercial payers, and a lot of times we win those appeals, and sometimes that works out really well. But for Medicare, yes, absolutely. Um, this question's a little. It basically is asking, you mentioned earlier about the utilization of TOPS adjacent to a fusion. Maybe you could explain how that would work. I don't know whether this is a one or two level fusion this particular person has, but
Sure.
if you're thinking adjacent to a fusion, how would that work?
So far, the way I've done it, and I've actually just spoke with another surgeon in Naples who's doing it, not to call him out, but there would be two ways to do it. Basically, you would either remove all the screws and place just new screws the level that you're operating on above the fusion. So you'd either remove everything and just put screws in at the level adjacent, assuming that that fusion has like a solid bone mass. If for some reason you needed to keep them in, then you would like connect onto them. Um, the TOPS does make a connector, so that could be done. So that would be the two options I would say. And I just want to add while I have the mic that I really have enjoyed it, and I'm definitely a big believer in it. I'm happy that I have this as an option for patients. I can't say that it's, solving every single problem in spine, but I find myself gravitating towards TOPS when I see a
Hmm.
degenerative spondy with severe stenosis because essentially if you're new to the conversation about this, the fusion it can be super helpful for quite a lot of problems we have, and it's one of our our mainstays in spine surgery, but it also has a downside, which is that it fixates that bone and it puts stress on the level above and below. And that's the main downside is that you hear about these patients who've had surgery after surgery after surgery every 2 years. And this is like, this is what you hear about. And this is, I think, why fusion gets a bad name. And rightfully so in some ways.
Here's a question. Essentially, this patient feels like has been diagnosed. Well, the doctor told me I have a failed laminectomy. Would I be, without knowing anything else, would I be a candidate for TOPS?
Hmm. Oftentimes, I'd have to see the scan, obviously, but a lot of times when I hear failed laminectomy, I'm thinking about primarily back pain as the main symptom. If that's the case, then we'd have to look at it critically, get a CT and MRI. If there's a level that's unstable, then, and it's maybe like a spondylolisthesis, then possibly TOPS would be a great case for that. Or if another case where TOPS would be helpful is if there's a level that's still stenotic after the laminectomy and you're having some leg, buttock, kind of mostly I imagine it would be buttock and leg pain. Then you could go in, re-decompress that level, and then put the TOPS device. I actually have done a case like that. A gentleman who had a two-level laminectomy, and putting in the TOPS device allows us to decompress the foramen and lateral recess very widely. So I could conceive of those two situations where one, maybe there's some instability, or two, the decompression was not enough, and there needs to be some more. So that would be my. So maybe check the MRI report, see if there's any, where they say moderate or severe lateral recess stenosis or severe foraminal stenosis, and in those cases, possibly the TOPS could be an option.
Got a couple of questions here that are similar, so I think I'm going to blend them a little bit. How long does the procedure take?
I'd say about 3 hours, roughly.
Um, Follow-up question on that then is how long is the recovery?
Generally speaking, I want to say 6 weeks. Yeah, can be shorter or longer. Some patients are like feeling amazing after 2 weeks, but I think six would be kind of conservative. You could even say 12 weeks if you really want to be conservative. In a fusion case, I'm usually going to say 12. In this, I'm usually going to say six.
Makes sense. A follow-up question on that is about essentially the longevity of the lifespan of the device itself. So how long should we expect for that device to last?
Yeah, that's a great
I can
question.
answer that. I know you're educated on that. If you want to answer that, please do.
I'll just comment that I know that there's, literature from overseas with over 10-year follow-up. And why don't you hop in there, Jeff, and add on to that. I know that there's literature out to 10 years. Um, the device does not move like a hip replacement does. Like a hip replacement requires so much motion that you would think a lot. You really have to consider wear of the device. And this, it's moving a bit, but it's not going to wear out as quickly as something like that. Jeff, what are your thoughts?
Yeah, well, we actually have patients out 20 years with the original device. Now, that original device is a little different than this device, but in some of the early devices in Europe were definitely, there's another data set that's out 11 years. So that might have been what you were referencing. So um, we don't really see
That was
any
11-year
issues.
study in JNS.
Yeah, yeah. So we don't really see any lifespan issues with the device. And I think you make a really good point. I mean, when you think about shear forces on the device, as long as the device is placed appropriately, it is designed to last a very long time with the materials that are in it. And once again, implanted appropriately, it's not going to have a lot of as much shear force as say an artificial knee or a hip would have on it. So and it's designed out of like titanium, just out of the same materials, and so it's going to last for sure. Um, there was a question here about the VA. I can answer that one. Yes, this is available at the VA. Depends on where you are in the country. I know that the VA in Central Florida definitely is using it. I think VA in South Florida as well as it's available. So it just depends on. I'm not sure where this patient is from, but it's definitely available in the VA. Multi-level disc disease with spinal. Okay, here's one. This might be an interesting one. A multi-level lumbar spine degenerative disc disease with spinal canal stenosis. Am I a candidate for TOPS?
Yes. And to be fair, you may just need a laminectomy too. We don't want to, do extra surgery. So we would look at an X-ray and see how the alignment is. If there's no spondylolisthesis, then you wouldn't even need a TOPS. A laminectomy would suffice in that kind of case. Um, and again, I want to bring up the point that if the issue is back pain, then it gets a little more complicated because our treatments for back pain sometimes are not as targeted, and we don't always know what the cause of the back pain is. Now, if you have neurogenic claudication and leg pain and stenosis related pain in the buttock or legs, then those patients tend to do very well from with surgery. Um, and so long answer to the question, but yes, it could be a TOPS case, maybe just a laminectomy. um, depending if there's actually a spondylolisthesis. Because remember, that's sort of what we're working here. The reason we're adding more stabilization is if there's actually a slippage of the bone.
But well, there's a couple of other questions that I think are are relevant to that particular question. And perhaps I would just ask it like this: is how do you evaluate the disc? So you have a patient with a up to a grade 1 spondylolisthesis with a stenosis, but you need to evaluate the disc to ensure that they're a candidate as well. So maybe you can walk us through how you
Yeah.
evaluate the disc and what's the minimum disc height and health of the disc that you're looking for to make sure that it works.
Sure. There's 4 millimeters is considered to be the minimum disc height. And one thing, I like to look at the stir sequence on the MRI to see, is this disc, the T2 and the stir sequences will tell us, is this disc extremely degenerative? Is it totally collapsed and there's a bunch of in plate changes? The patient maybe has a lot of back pain or something, then, that then may be a contraindication. Additionally, a CT scan is helpful to see how degenerative the disc is. That's one of the great benefits of a CT. You can see sometimes the disc looks okay on the MRI, you get the CT and it's just air. And then that disc is completely shot, so to speak. So CT, MRI, X-ray, we sort of classify the disc degeneration. You can use this like the Furman classification, or you can, just sort of qualitatively describe the disc and look at its height. It should be greater than 4 millimeters. We can get a CT scan and see to evaluate the end plates and see if there's air in the disc.
Okay, great. Well, thank you. Look, we're at the half hour. Dr. Burks, thank you for your time. I really appreciate it.
My pleasure.
Um,